give you a little bit of an overview today. It'll be data light, but I'm going to focus most of the time today on trying to give you a little bit deeper perspective on how we sense pain, what pain is, and what some of the issues are in terms of trying to understand the basic science underlying pain, both in an acute setting and a chronic setting. And so just start off. There we go. So this is, pain is a sensation that's familiar to all of us, and one of the things about it is that it has a disturbing, aversive quality to it. And in fact, that's part of the fundamental definition of pain. So we'll just start off with a couple definitions here. Pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with either actual or potential tissue damage, or described in terms of such damage. And so the long and the short of this is that pain is a sensory experience. It's an emergent property of the nervous system. It's not something that one neuron does in isolation, but rather it's this array of sensory features that emerge when either we damage our own tissues or when we experience some sort of stimulus that our body interprets as being potentially damaging. A more limited concept is that of nociception, and nociception just refers to the detection of stimuli that are potentially painful. So an isolated neuron is capable of carrying out nociception because it can detect mechanical pressure or heat, but it can't experience pain as far as we can tell. And then finally, a term that I think will become much more relevant as you hear later in the day from the speakers who are describing the clinical aspects of pain is the phenomenon of hyperalgesia. And this basically means that you have an augmented perception of pain or feeling pain in response to a stimulus that was formerly non-painful. And just to give you a direct example of this, if you have a sunburn, your skin is much more painful to touch or to heat than it was before you had the sunburn. Now, in thinking about the mechanisms that underlie pain, it's useful sometimes to think about how we might be able to classify different pain experiences. So in humans, for example, there's a very important distinction between acute pain, which lasts seconds to days, versus chronic pain, which can last weeks to years. And what I mean by this is that acute pain is adaptive. It serves a function. It helps us to avoid dangerous situations in our environment. It helps us, as Randy Reed pointed out earlier, it helps us to protect our injured tissues so they have a chance to heal. But if the sensation of pain far outlives the noxious insult that caused it, then it becomes chronic pain, and that's actually quite maladaptive. It leads to a tremendous decrease in quality of life for patients and tremendous losses of productivity. The other sort of characterization or classification that's worth thinking about reflects the mechanisms of origin of chronic pain. So when you have chronic pain, it can be due to a number of different causes. And it turns out that it matters what it is that triggers that chronic pain. So for example, we can talk about inflammatory pain, which came up both in Paul Fuchs and Randy Reed's talks. This is chronic pain that can arise from either injury or inflammation in target tissues. So if you get a bee sting or if you have rheumatoid arthritis, these are peripheral processes in the organs that are innervated by our neurons that are constitutively activating the nervous system and producing this long-term sensation of hyperalgesia and elevated pain. On the other hand, you can have neuropathic pain, and this is pain that arises from direct damage to the neurons themselves. In some cases, it's the neurons in our peripheral nervous system. So, for example, sciatic nerve pain, which runs along the length of the leg and can go down to the feet, can be due to damage actually to the sciatic nerve in the leg or its origins in the back. Whereas central neuropathic pain arises from damage to structures in the spinal cord or in the brain. So for example, some patients who have a stroke or who have spinal cord injury can end up with chronic pain syndromes, not because of changes in our periphery, but because of changes in the way our central nervous system interprets incoming signals. So to put this in an anatomical context, this is sort of the low-budget view of the pathway in our nervous system that leads to the perception of pain. So very often pain starts with some sort of insult in the periphery. That can be a mechanical, a chemical, a thermal, or an electrical stimulus. And the neurons that are responsible for detecting these noxious insults are referred to as primary afferent nociceptors. These are sensory neurons that innervate our big toe and other structures in our bodies. And these neurons have their cell bodies in structures called the dorsal root ganglia. These are paired structures that reside at every level of our spinal cord, and there's one on each side. And within those ganglia, we have a whole bunch of cell bodies, and they're stained here in a figure from Xinjiang Dong's lab with different neurochemical markers. The specific markers here aren't important, but this is just to illustrate that these sensory neurons that innervate our skin are quite heterogeneous. They vary in size, they vary in terms of the molecules that they express, and only a subset of these neurons are actually classified as nociceptors. Only a subset of them are functionally capable of discriminating painful from non-painful stimuli. These neurons, like the other somatosensory neurons, give off two branches. One goes out to our big toe, and the other one enters the spinal cord. And so when you activate these neurons in your big toe, action potentials fire and they get transmitted past this ganglion and into the spinal cord. In the spinal cord, there's neurotransmission between this primary neuron and the next neuron in the chain. And that next neuron in the chain actually crosses from one side of the body to the other and then ascends all the way up to the brain. It goes up to an area called the thalamus, and then from there you have tertiary neurons that go up to the cortex. And so it's this pathway, activation of neurons way out here, that results in a complex series of changes in the brain that give us this complex perception of pain.
Excuse me, Doctor.
Yeah.
So in that pathway, where does the emotional experience come in?
Ah, good question. So where does the emotional content of pain come from? It turns out there are two areas of the cortex, one called the insular cortex and one called the anterior cingulate cortex. And those two areas of the brain are involved in encoding the emotional content of pain. In fact, you can light up, if you do what's called functional MRI imaging of the brain, you can light up those regions of the brain either by causing pain to the tissues or by making the patient angry, or by showing them faces that have either happiness or anger. So this events that lead to an emotional experience activate the same areas in our brain as events that lead to noxious pain. The other thing I want to mention in that regard is that, now that you brought it up, is that I'm describing this as though it's one pathway. But actually there were at least two different pathways by which pain-related information reaches the brain. One of those pathways specifically targets these emotional centers of the brain. The other pathway specifically targets what's called the somatosensory cortex, and it's involved in the more dispassionate aspects of evaluating pain, telling us where does it hurt, when did it start hurting, and how strongly does it hurt. So the emotional and the what are called sensory discriminative aspects of pain are actually anatomically segregated from one another.
And do you think the emotional context or the emotional component is also adaptive?
Yes, both of them are.
Okay.
Both of them are.
Thank you.
Now, whether it's adaptive by exactly the same mechanisms as the non-emotional content is unclear. Probably they're dissociable from one another. And there are drugs, for example, that can make pain bother us a little bit less.